Yes, ma'am, we can hear you just fine.
My slides? Not able to hear.
I can hear you.
Okay,
And,
all right.
and your slides look great.
Okay, great. Thank you so much. So I'm going to go ahead and get started if that's okay. My name is Jimenez Shahed. I'm a movement neurologist at the School of Medicine at Mount Sinai, and we'll be talking this morning about tardive dyskinesia across the complexity spectrum, and we'll talk about a whole range of kind of topics related to this. Okay, yeah, there's my intro slide. I do have some consulting work with Bracket, Involution, and Teva related to development of one of these drugs. And this is a CME program provided by the MAC. So our learning objectives for today are to describe an updated recommendation and screening strategies for improved TD recognition across the spectrum of severity and symptoms, integrating key clinical data and updating guideline recommendations for treatment with Vmat2 inhibitors into our clinical practices, and then developing a cross-disciplinary care plan with psychiatry clinicians to facilitate improved collaboration for the care of these patients. So as you probably are all familiar, there has been kind of an exploding use of atypical antipsychotic drugs as a result of the expanding list of indications for these medications. And the most recent data from 2018 indicates that about 7.3 million patients are being prescribed these types of drugs. Of those, the vast majority are being prescribed the atypical antipsychotics, and about 1.3 million still receive prescriptions for typical antipsychotic drugs. And of course, this is concerning because of, as we'll talk about, the increasing risk of exposure, or the increasing exposure increases the risk of tardive dyskinesia itself. So what is tardive dyskinesia? Let's start by just defining that. It's a type of dyskinesia that typically emerges after long-term use of dopamine receptor blocking drugs, including most commonly the antipsychotic medications, but also a subgroup of antiemetic and GI prokinetic medications. So if you break down the term tardive dyskinesia, tardive, of course, indicates that this is a condition that appears or tends to appear later in the course of treatment. This is not generally something that shows up as soon as these medications are started. And dyskinesia is just a generic term that implies that there's an impairment of voluntary movement or abnormal movements that are present. And so this is a problematic condition because it can be socially stigmatizing, functionally impairing for patients. And once people develop it, there's really only a very small minority of patients who will actually be able to get rid of their tardive dyskinesia. So we need to be very vigilant about our prescription of these drugs and our understanding of the risk of patients developing this particular syndrome or this condition. Now, we'll use the term tardive dyskinesia throughout this presentation, but there is a move towards defining this more as a tardive syndrome, simply because there can be different phenomenologies that patients experience within the umbrella of this involuntary movement disorder. And so we'll talk a little bit about what those other presentations are. So if we break down the risk or the different types of movement disorders that are associated with medications that block dopamine receptors, you can think of them a little bit in terms of sort of the time course of their development. So there are certainly some acute movement disorders that can occur upon exposure to these dopamine receptor blocking drugs. Those are things like acute dystonic reactions or ocular gyrate crises. You can have a more subacute presentation, maybe within days or weeks. These are things like neuroleptic malignant syndrome, akathisia, Parkinsonism. And then we have the cluster of tardive disorders, which all require the exposure to dopamine receptor blocking drugs, but as we talked about, will show up later in the course of that exposure. And we'll talk specifically about definition in a moment. But there are, as I mentioned, different phenomenologies of movements. You can have sort of the classic dyskinesia, you can have a more dystonic presentation, you can have akathisia, you can have a combination of these different types of movements, plus some other ones that can sometimes show up as well, but we'll talk about the most common ones. The clinical diagnosis of tardive dyskinesia can be made in a couple ways. There is a Schuyler-Kane diagnostic criteria for tardive dyskinesia. These are largely used for research, and probably the ones that we are more familiar with and use more regularly in our practices are probably the DSM-5 criteria. And so those are shown at the bottom of the slide, and these include involuntary athetoid or choreiform movements that have been lasting for at least a few weeks, that have developed in association with the use of a neuroleptic medication for at least a few months. Okay, and so this time frame is a little bit vague in the DSM-5 definition, but I think it just conveys the idea that the exposure should have been longer, and the presence of the movement disorders being a little bit more long-standing in order to kind of make the diagnosis. They also point out in the DSM-5 criteria that these involuntary movements can appear after discontinuation of the drug or after the dosage of the medications are changed or reduced, and that's important to remember because there is sort of a subset of patients that have something called withdrawal emergent dyskinesia, and that's usually a time-limited phenomenon in which patients may experience these types of involuntary movements for less than 4 to 8 weeks after the reduction or the discontinuation of these medications. And any dyskinesias that persist beyond that time window are really considered more the tardive dyskinesia and have a greater risk of permanency. And there are certainly patients, and this is acknowledged in the DSM-5 as well, certain patients where they might develop a TD phenomenology after exposure to a shorter duration of these medications. And so just recognize that there can be some variability, although these are the diagnostic criteria. So what is kind of the classic tardive dyskinesia? So when people think about tardive dyskinesia, they're often thinking about the orobucolingual stereotypies. There can also be some choreiform movements in the distal limbs. Front can be involved, and there can be some respiratory muscle involvement as well, and patients may complain of sort of being short of breath at times. And the pattern of movements that we'll see in this presentation, as I mentioned, the tongue movements, the mouth movements, the chewing movements. In the hands and feet, you might see those piano playing finger movements. There might be some truncal rocking. Patients might be marching in place. We mentioned the respiratory dyskinesias. And these are usually just sort of repetitive movements. They can be suppressed by voluntary tasks briefly, but usually, in the context of your observation or throughout your visit with the patient, you'll see them kind of reemerge continuously. They're pretty much always present, and they can increase with stress, as most movement disorders can, and they can be variably distractible. So it's very important to watch carefully as you're interviewing patients who have these exposures. So here's a couple of videos. This is a kind of a classic orobucolingual stereotypy here. This is a woman who you'll see some mouth movements here as well. This lady, although she has cervical dystonia, there is also some coexisting orobucal movements. Same with this lady, she's got some head stereotypies along with the mouth movements. And now here's a patient who has a little bit what looks more like kind of a restlessness. And here's a patient with sort of some subtle mouth movements that you're kind of only seeing under certain examination tactics. And then this is a patient with tongue movements that you might not even be aware are present until you ask the patient to open their mouth and look at what's going on with their tongue. So again, a broad range of possibilities. Now, another kind of major phenotype of tardive dyskinesia is actually tardive dystonia. Okay, so dystonia is kind of a more sustained muscle contraction that creates an abnormal posture. And these can be, as with any kind of dystonia that you might learn about or come across, they can be focal dystonias, they can be segmental dystonias. Often they do involve the face, head, neck, or trunk. And so you might see patients with repetitive eye blinking, jaw kind of tightening, or even jaw opening, tongue protrusion, that kind of eye movements, the ocular gyric type of things. But a very classic one is actually retrocollis with epistotonic posturing. And these are, dystonic and different from those stereotypic and choreic movements that we talked about in the previous slide. But it's important to recognize that they can also occur in combination with the orobucolingual movement. So patients may have multiple sort of phenomenologies present within their tardive presentation. And these dystonia type TDs are often painful, and so patients will complain about tightness of their muscles and discomfort associated with those abnormal postures. So again, pulling, twisting, sustained repetitive movements or postures, usually worse with action. And a very classic patient group that will develop or present with tardive dystonia as their manifestation are younger males who have been exposed to these neuroleptic medications for psychiatric reasons. And so they'll have that kind of epistotonic, retrocollis, shoulder internal rotation type of presentation, and they're often quite uncomfortable with that, with those types of movements. Now, the third kind of major presentation of tardive dyskinesia or tardive syndrome is a tardive akathisia. Okay, so akathisia is where you have a very strong sensory component associated with the involuntary movement. So the patients will describe, this uncomfortable sensation, and they're really kind of volitionally getting up and moving around, or, moving their limbs or extremities in order to relieve those symptoms. And so that akathisia is slightly different because of that sensory kind of component to it. And this is often, again, seen in combination with other tardive stereotypies, and again, can be quite distressing and uncomfortable for patients. They're often in a constant state of movements. You'll see them sort of sitting in the chair, kind of constantly kicking or rocking their trunk. They might be getting up and walking around and pacing in your examination room. There might be some kind of verbalization or moaning that goes along with that because of their discomfort. And so very kind of distinct presentation compared to the other involuntary movements that we talked about. So what is generally the clinical course of tardive dyskinesia? Well, this kind of slide predicts a typical time course. Patients might begin a dopamine receptor blocking drug. They've been taking it for a few months, and then the tardive dyskinesia can occur as soon as 3 months of exposure. But it usually occurs within 1 or 2 years of therapy, and as we talked about in the diagnostic criteria, it can present after discontinuation. So there's kind of a whole range, and we just need to have a high index of suspicion when we see somebody with involuntary movements who has had a known exposure to a dopamine receptor blocking drug. And of course, the phenomenology, as we talked about, can be variable. And the severity can also be variable, all the way from kind of mild and maybe patients aren't even aware of some of the movements that they have, towards kind of the full spectrum and severity of being very disabling and uncomfortable for the patient. And although these symptoms are chronic, they might vary in severity over time, and so just recognize that may happen. And as we talked about, there's a high kind of risk of permanency of these abnormal movements. And so following discontinuation of neuroleptic therapy, as we'll talk about, that might be an appropriate strategy in some patients. The symptoms of TD will continue in the vast majority, and estimates range from 67 to 89%. So just because we get them off of whatever the offending agent is, it doesn't necessarily mean that these will go away, and in fact, often the movements will. Now, when we think about who is going to develop tardive dyskinesia, there are a number of well-described risk factors. You can see them listed here on the right-hand side. I think this is important to recognize if you're especially in a position where you might be considering the use of dopamine receptor blocking medications in a patient. And so, we just advise that there should be some consideration of this risk profile. And if you see a patient, maybe carefully consider alternatives to the dopamine receptor blocking drugs for management of their condition. Now, the epidemiology of tardive dyskinesia is, it's evolving, meaning that generally speaking, these were often syndromes and conditions that were associated with use of the first-generation antipsychotics. But as this slide shows, even second-generation antipsychotics are associated with tardive dyskinesia. And so if you look at it any way you slice and dice it, whether it's the annualized tardive dyskinesia incidence, whether it's the risk and annualized rates, whether it's the overall prevalence of tardive dyskinesia, it's always higher in all of these large studies with the first-generation antipsychotics, but it's not absent with the second-generation antipsychotics. So just because we're using kind of the newer second, third-generation medications doesn't necessarily mean that patients don't have the potential risk, and so we need to be aware of that as well. Now, what are the consequences of chronic D2 receptor blockade? This really tends to kind of create a persistent hyperdopaminergic state. So if you look at the left-hand image on this slide, it's showing the blockade of the D2 receptors in the nigrostriatal dopaminergic pathway, which is what happens when you're using these medications, and that causes those postsynaptic receptors to upregulate. And when they upregulate, they subsequently become somewhat hypersensitive and have an increased affinity to dopamine. And so this upregulation is what's thought to lead to tardive dyskinesia, because you get this kind of excess inhibition of the stop signal resulting in the excess go signal, and that's what gives us that imbalance within the direct and the indirect pathways and creates that kind of hyperkinetic movement disorder. And this is important to kind of recognize, especially when you may be dealing with some of the more complex patients who may present with tardive dyskinesia, that other medications that they might be exposed to or need to be using that actually increase dopamine levels can actually exacerbate tardive dyskinesia, because now it's just driving the direct pathway, which is already now dysregulated in the context of the tardive dyskinesia. So we have to be very cautious of that, as we'll talk about in subsequent slides, in patients who might have coexistent Parkinson's. There are other hypotheses about how tardive dyskinesia, the pathophysiology of it, and so there is some literature on the D3 receptor hypersensitivity, maladaptive plasticity, synaptic morphological changes, and potentially even the role of genetics impacting the dopaminergic system that might put certain patients at increased risk. So it's still a very kind of dynamic field in terms of our complete understanding of who gets it and why, but there are several different theories, as I mentioned. We also know that tardive dyskinesia, from purely from a patient perspective, can have impacts on many, many different aspects of their lives. And so if we start on, kind of the top right-hand corner here, of course, their individual functioning may be quite affected by their TD symptoms in terms of quality of life, ability to work, ability to perform their ADLs. And there may be, of course, some psychosocial impacts as well, because as these patients are embarrassed by their symptoms, they might reduce their leisure activities, their friendships, their relationships. They may have difficulty with employment. They may, experience social avoidance and withdrawal, and certainly a fair amount of embarrassment about their symptoms. And then from a physical standpoint, on the bottom left-hand side here of the slide, these movements can create other types of physical issues for the patients in terms of things like dental damage, bite injuries. They're having trouble with manipulating their food. There may be the pain and discomfort, as we talked about, breathing difficulty, speech issues, gait and balance issues as a consequence of the involuntary movements. And then we know that there can also be impacts up here on the top left-hand corner on their psychiatric stability as a consequence. So they may be at risk of poor response to treatment, having relapses or readmission of a psychiatric disorder, more anxiety and depression. And then if you put that into the context of then having some constraints on their antipsychotic medications, you can understand how this may create a very complicated situation for these types of patients. Let's move on to just a little bit more of the recognition aspect of tardive dyskinesia. So tardive dyskinesia is often, lumped into the category of things that are otherwise referred to as extrapyramidal symptoms. And I kind of don't always like that terminology, because I think it gets kind of freely used to describe anything that can happen in a patient who is being treated with these kind of medications. And so just recognize that there are, these different types of disorders that are lumped into that category of EPS, and maybe just try carefully to be distinct about what you think it is that is going on with the patient. So is it tardive dyskinesia, or is it something a little bit different, which is drug-induced Parkinsonism? Are they experiencing other forms of dystonias or akathisia? And certainly there are some other drug-induced movement disorders that can be present, like a drug-induced tremor or something of that nature. So when you think about the fact that all of these different types of problems can result from the same type of thing, which is exposure to these medications, you can see how it is very important, and as we'll illustrate in a couple of slides, why it's so important to actually be specific about the actual phenomenology of the movements, because I think that will help dictate the treatment and guide you in terms of your decision making about what to do. And specifically when we're talking about things like drug-induced Parkinsonism, again, that can frequently coexist with the tardive dyskinesia, and so that can get tricky, as we talked about in terms of the management. So because of these reasons, I think it is really important for us to collaborate with our psychiatry colleagues. Psychiatrists may refer patients to neurology in this context for a variety of different reasons. Maybe it has to do with some uncertainty about the diagnosis. Maybe there's some atypical features. Maybe there's a family history of other movement disorders or pre-existing movement disorders that now seem to be worse. Maybe the patient has the dystonia and there's a request maybe for specific treatment modalities such as botulinum toxin injections, for example, when dystonia is present. Maybe these patients are having difficulty with their response to the drug treatment, or maybe they have a persistent Parkinsonism after their antipsychotic medication has been adjusted or stopped. So there are many different reasons that we might come into contact with these patients, and I think, again, highlights the importance that we have a careful line of communication with our colleagues about how to manage them. Now, one of the things that psychiatrists are recommended to do is to assess tardive dyskinesia symptoms periodically in patients who are taking antipsychotic medications. And the way that that is usually done is using the AIMS scale. So AIMS is the Abnormal Involuntary Movement Scale. It's broken down, as you see here on this slide, into the top 7 items, which are the different body regions that you will score whether involuntary movements are present. So part of the challenge with the AIMS scale is that it doesn't necessarily specify which movements should be rated. And so a lot of different movements might be something that fall into the rating for an individual body part. So for example, if there was coexistent dystonia and dyskinesia, you really would just kind of rate whichever one, the highest manifestation of either one of those. And so it's a little imprecise in that way because it's not telling you a lot about just the specific type of movement disorder. It's really just giving you a rough kind of understanding of the overall involuntary movements that the patient is experiencing. And so you score these different body parts on a score of 0 to 4. So the maximum is 28 as far as from the actual movement problem. And then there's an item 8, which is actually the severity of the abnormal movements overall, and you just pick the highest score of all of those body regions to kind of score as a global kind of severity. And so this is really, this blue box down here shows us the rating scale, which is 0 is no movements in that body region, 1 is minimal, 2 is mild, 3 is moderate, and 4 is severe. So there's a certain amount of subjectivity in this assessment, but you know, it is a reliable tool and is the one that is recommended for use for ongoing monitoring of these patients. So, you know, changing kind of gears just a little bit, we mentioned about this, being able to distinguish between tardive dyskinesia and drug-induced Parkinsonism, and this is really an important thing to be able to do. So drug-induced Parkinsonism, as we talked about, is more of the subacute, falls into the subacute time frame after exposure to these neuroleptics, although you can certainly see it present later. But the earliest that it was present is in that kind of few weeks or early time period after exposure. And again, it can happen after initiation of these medications or after a dosage adjustment. And as we know with Parkinsonism, there is tremor, there can be rigidity, there can be bradykinesia, and you know, sometimes the tremor of Parkinsonism will be confused with the tardive dyskinesia movements. And so just remember that tremor is rhythmic versus some of those other movements that we saw in those previous videos, which were not rhythmic. And usually the tremor is kind of faster than those kind of involuntary movements that we saw. And the bradykinesia and rigidity are also essential sort of coexisting components in order to be able to determine that somebody actually has Parkinsonism and be aware of your examination and how to look for those things. And then this can often, as we talked about, the Parkinsonism itself can coexist with the TD. And so we need to be able to distinguish which is which. Now, one key difference with Parkinsonism is that it will resolve with dopamine receptor blocker discontinuation. Although it may persist for months and it may take quite a while for it to go away, it will go away versus the TD, as we talked about, which it won't. So here's some videos of patients with some Parkinsonism. Here's a gentleman with some left upper extremity resting tremor you see here. And it's not major, it's in the finger. Here's a little bit of jaw tremor as well. You can see some postural tremor here in the right side, so there might be some mixed kind of presentations. This, of course, as we all know, is testing for bradykinesia. This is testing for rigidity, so we want to be sure that we do that in conjunction with using these kind of distracting or amplification maneuvers in order to really bring it out. And then, of course, as we assess the gait, this guy doesn't look too terribly Parkinsonian with his gait, but there is a reduced arm swing on the right side. So that's it's kind of a subtle finding there that you might want to look for. And then Yeah, I think that's it for that particular video. So again, the examination, as we do kind of a global examination on these patients, but you need to be vigilant about some of the things that look like Parkinsonism versus that look like tardive dyskinesia. I'm going to skip that slide there just for a moment. So again, part of the reason why it's so important to be able to distinguish between the phenomenologies is because the treatment responses will differ quite significantly. So for example, if we look at the response to patients with either tardive dyskinesia or drug-induced Parkinsonism, what happens if you actually increase the antipsychotic dose? In TD, it may temporarily actually mask the movement disorder, but in drug-induced Parkinsonism, it will get worse. If you decrease the antipsychotic drug in tardive dyskinesia, that may induce a withdrawal emergent dyskinesia, as we talked about, or if you do that in the chronic stages, you might actually be preventing the worsening of the tardive dyskinesia. In drug-induced Parkinsonism, usually when you reduce the dose, that will improve or resolve the Parkinsonism. Now, anticholinergics are another kind of important medication group to understand in terms of the dynamics between tardive dyskinesia and drug-induced Parkinsonism. There's actually a fair amount of evidence that anticholinergic medications may worsen tardive dyskinesia, and so we often see patients with exposure who are being actively treated with antipsychotic medications who are also kind of alongside also being treated with anticholinergic medications. And if you then see these patients in the context of the development of their tardive dyskinesia, one of the first things you should think about doing is actually discontinuing the anticholinergic medication to see if that alone will improve their tardive dyskinesia. Now, on the other hand, with drug-induced Parkinsonism, especially if there's tremor, we know that anticholinergic medications can actually help Parkinsonian tremor. And so that is something to distinguish the two phenotypes as well. Now, Vmat2 inhibitors, as we'll talk about, are the emerging class of medication for treatment of tardive dyskinesia. And so these are, of course, indicated for TD and will improve TD symptoms if you use them in the appropriate context. However, if you have a patient with drug-induced Parkinsonism and you put them on a Vmat2 inhibitor, there is definitely a risk that you might worsen the Parkinsonism because, as we'll talk about, Vmat2 inhibition is another way of reducing dopaminergic tone and dopaminergic signaling. So this may aggravate Parkinsonism. And then the last drug that's kind of on this slide is Amantadine, which is kind of as hopefully you know, kind of a complicated medication. We most commonly use it for treatment of levodopa-induced dyskinesias, and similarly, it can, for some patients, improve their tardive dyskinesia. It's certainly not expected to worsen the TD, and also in drug-induced Parkinsonism, it might actually help some of the bradykinesia, the rigidity, the tremor, and so is one of the few drugs that can actually be used safely and without too much risk in both groups of patients when there's tardive dyskinesia present or when there's drug-induced Parkinsonism. So I think, because these conditions so frequently coexist, as I've mentioned several times now, there can be some management challenges, and so you really want to think about these dynamics and potentially consider something like Amantadine when both of these conditions coexist, along with some of the other strategies that we'll talk about. All right, so now how do we actually treat tardive dyskinesia? Well, the goals of treatment in tardive dyskinesia are multiple, right? So if the patient is developing their tardive dyskinesia because they took antipsychotic medications for a psychiatric indication, we of course want to maintain psychiatric stability. And again, this gets back to the importance of being in good communication with the psychiatrist who is managing that patient's psychiatric condition. We are generally not trying to attempt to eliminate all of the tardive dyskinesia, just because if we really are pushing doses of these medications, we run the risk or greater risk of the patient developing adverse effects. And so we need to be careful about that, and really, maybe we're trying to get the symptoms to a manageable range so that they are no longer impacting the quality of life in the way that they otherwise. And again, there's several ways to assess that, whether it has to do with the patient's activities of daily living, whether it has to do with the physical problems that result from the tardive dyskinesia, whether it is important for the patient to have better social functioning or reduced embarrassment from their symptoms. All of these are reasonable goals in terms of the treatment. And so there's several different ways to kind of slice and dice it, as in many of the things that we do from a neurology. Now, historically, the management of tardive dyskinesia has been as follows: a strong push for prevention, and I think that is still, a very important component of preventing a tardive or of management of tardive dyskinesia is the actual prevention of it. In the past, we used to advocate removal of the causative drug, and that still may be quite an appropriate intervention for certain patients. If this is something that is done, it should be engaged in a gradual process as opposed to sudden withdrawal, again, because of the risk of the withdrawal emergent dyskinesias. And certainly in a patient with underlying psychosis or other psychiatric instability, stopping those antipsychotics quickly can certainly worsen their underlying psychiatric disorder, so we don't want to do that. We did in the past often recommend switching the patient from an atypical switching the patient to an atypical medication that has lower antidopaminergic potency, and the two that have been generally the most advocated are things like quetiapine and clozapine, and that certainly might still be a reasonable strategy in some patients, but will depend on their underlying psychiatric disturbance and the original indication for the dopamine receptor blocking drug. And there's just a kind of a caution here that restarting or increasing the dose of a causative dopamine receptor blocking agent or something similar can reduce tardive dyskinesia. This used to be something that was done a little bit more frequently. If the patient started developing, kind of a TD, then the dose of the antipsychotic would actually be increased because that would initially mask the symptoms. But I think that is a really challenging proposition these days, especially because there are alternative treatments. And because we know that continued exposure and certainly increased doses can increase and potentiate the risk of the tardive dyskinesia itself. So this really should not be a strategy that's used in our current management landscape. Other things that can be done and historically have been done is avoid about the anticholinergic medications. Some have used GABA agonistic medications like clonazepam, baclofen, valproic acid with varying degrees of success. And certainly there's a literature in the past about other medications such as the amantadine, donepezil, branched chain amino acids, and vitamins for reduction of tardive dyskinesia use. And you should be aware of those and maybe use them in certain situations as appropriate. But the magnitude of benefit generally with those approaches is relatively. So this is the American Academy of Neurology guidelines pertaining specifically to some of the medication management strategies that used to be used in the past. Clonazepam was given moderate support, ginkgo biloba moderate support, amantadine weak support, and tetrabenazine weak support. So tetrabenazine is the kind of earliest Vmat2 inhibitor, and I think the recommendation here that it can possibly reduce TD symptoms is really just a function of the fact that there were no randomized controlled trials of tardive dyskinesia using this medication. And we'll talk again in a couple of slides about what randomized controlled trial evidence we have about this class of medications now. All right, so the modern management of tardive dyskinesia is as follows. So we have several different types of dopamine depleting drugs, tetrabenazine being the original one, but as we mentioned, was not studied in a randomized controlled trial of tardive dyskinesia, and so is not FDA approved for that indication. However, tetrabenazine and valbenezin are both FDA approved for management of tardive dyskinesia. Amantadine is not, clonazepam is not, but certainly can be adjunctive treatments that we use in the appropriate patient. And then chemodenervation for some of those particular dystonic types of phenotypes with tardive dyskinesia can certainly be used, although not the specific FDA indication. And then DBS in really severe or refractory cases can also be considered. So what are Vmat2 inhibitors? Well, Vmat2 inhibitors are a group of medications that tend to deplete dopamine. So what the heck does that mean? So there are different types of Vmats. Okay, so Vmat is vesicular monoamine transporter. There's a type 1 and a type 2. The type 1 transporters are generally not present in the brain, and the Vmat2 category is extensively distributed in the cortex, the striatum, and the basal ganglia, and is generally found in the presynaptic dopaminergic neurons. So here's a presynaptic dopaminergic neuron. It is manufacturing dopamine from using tyrosine hydroxylase activity. And once the dopamine is actually manufactured, the way that it gets released into the synaptic cleft is that it is incorporated into a synaptic vesicle. And the way to incorporate dopamine into the synaptic vesicle is the vesicular monoamine transporter type 2. So when you block the Vmat2 molecule, then the dopamine can't get incorporated into the synaptic vesicle, and so then the synaptic vesicle has nothing to release into the synaptic cleft once it merges with the synapse, with the membrane. And so the dopamine that is not incorporated into these vesicles is then rapidly degraded within this presynaptic neuron. And that's why we call this group of medications, often refer to them as dopamine depleting medications. It's important to remember that all of these Vmat2 inhibitors, as you can see in the slide, they all work presynaptically. So there's absolutely no postsynaptic mechanism of action in these medications, and that's what differentiates them from the dopamine receptor blockers. So even though dopamine receptor blockers also reduce dopaminergic transmission, they're doing it in a completely postsynaptic way versus the Vmat2 inhibitors, which are doing it presynaptically, and that is thought to be the reason why Vmat2 inhibitors don't cause or potentiate tardive dyskinesia, and in fact can treat tardive dyskinesia symptoms. All right, give me 1 second here. I'm getting this really bright sun. Let me get that out of my face so I can actually see what I'm doing. Sorry about that. Okay, so the Vmat2 inhibitors that we have, tetrabenazine, valbenezin, and deutetrabenazine. So tetrabenazine was kind of introduced into the market several years ago now with the original indication of treatment of chorea in Huntington's disease. So it is a drug that can be used to treat certain hyperkinetic movement disorders. And the use of this medication in tardive dyskinesia was previously done sort of on a compassionate use basis or off-label. Valbenezin is and deutetrabenazine are kind of variants of tetrabenazine, and we'll talk about that in a couple of slides. But these were both approved in 2017 for specifically for management of tardive dyskinesia, and this was the first indication for valbenezin, and then for deutetrabenazine, it's also approved for the treatment of chorea associated with Huntington's disease. So there are slightly different medications, although they're all based on tetrabenazine. There are some differences in kind of the dosing strategy. So tetrabenazine, if you're familiar with it and have used it in managing Huntington's chorea, for example, it is a TID dosing schedule. So patients have to take the medication, usually breakfast, lunch, and dinner, and the reason for that is the half-life is relatively short, about 5 to 7 hours. Another kind of challenge with tetrabenazine is that the Cmax is about 1 to 2 hours, and so patients will often get sort of a peak concentration of or exposure to tetrabenazine soon after taking the dose. And this is, for some patients, thought to underlie the side effects that come from that medication, such as somnolence, sedation, akathisia, et cetera, et cetera. And so the other two compounds, deutetrabenazine and valbenezin, were kind of manufactured to address these pharmacokinetic issues. And so deutetrabenazine, as you see on this slide, is administered BID. It has a slightly kind of later Cmax, and a half-life is 9 to 10 hours. Valbenezin is administered once daily, again with a slightly later Cmax, and the half-life of up to 22 hours. So very different pharmacokinetic profiles with these medications, although they're based on the same base compound. So the evidence for tetrabenazine in tardive dyskinesia, as we mentioned, is not particularly robust. There was a blinded videotape Ames assessment, and it was an open label study actually of a small number of patients, 19 patients who were treated with up to 150 milligrams of tetrabenazine. And the TD did improve 54% in those patients, and a vast majority, or the majority of those patients did rate themselves as markedly improved. There was another long-term open label study with a larger number of patients, 149. But in this study, it was notable that several patients actually discontinued the medication because of adverse effects. And there were only 40% of patients who had no adverse effects. Of the AEs that were notable in this particular report, 27% included Parkinsonism, 24% drowsiness and fatigue, and 10% experienced akathisia. So sometimes this can be a challenging medication to use for that reason. So deutetrabenazine is, like I said, a kind of a pharmacologic manipulation of the base tetrabenazine compound. It uses a method called deuteration. And so you see what that difference is here on deutetrabenazine. Deutetrabenazine itself is similarly metabolized by hepatic carbonyl reductase to the active metabolites. So there's alpha and beta dihydrodeutetrabenazine. But then the CYP2D6 metabolism, the CYP2D6 metabolism of these medications is actually slowed because of the deuteration. And when you slow down that metabolism, you have accumulation of the active metabolites, and that's why the half-life and the Cmax and things like that are different, and why the dosing schedule for this medication is BID instead of TID for the tetrabenazine. So this is a depiction of the peak dose effect. So the yellow here is the tetrabenazine. So as I mentioned, patients may take tetrabenazine. They get a high kind of immediate sort of exposure to the medication that slowly tapers. With deutetrabenazine, you can see that that peak is blunted. And so it is thought that this blunting of the peak may lead to the better tolerability profile of something like deutetrabenazine, and less incidence of those things like sedation, akathisia, et cetera, et cetera. Now, valbenezin is kind of a slightly different way of improving the pharmacokinetic profile. So we talked about tetrabenazine being going through the carbonyl reductase process, and you get these different enantiomers. It's thought that this particular one highlighted here in yellow is the most active of these metabolites, and so valbenezin is a sort of, you can think of it, it's really just this version of the or formulation of the tetrabenazine, the dihydrotetrabenazine. So it is really trying to capitalize on the metabolite of tetrabenazine that is the most active and consequently also the better tolerated one. Some of the theories about the adverse effect from tetrabenazine relate to having these other kind of enantiomers around. So you can kind of almost think about it as sort of like a purified form of the active components of the tetrabenazine. So these drugs were studied in clinical trials, and so we'll walk through those in a little bit, or kind of in the next couple of slides. So deutetrabenazine, this is the fixed dose study designed for that medication, and the primary outcome measure was the change in the AIM score. The patients were treated either with 12 milligrams per day of the deutetrabenazine, 24 milligrams per day, or 36 milligrams per day. They had to go through an initial titration period. And the titration, I think it was over the 8 weeks. And then they had, I think, a 1 month maintenance period. And you can see that there's a dose-dependent response, basically, in the reduction in the AIM score. And this is also shown here on the right-hand side of the slide. So you had a little bit of improvement with 12 milligrams and a greater improvement with 24 or 36 milligrams per day. In terms of the reduction in the AIM score, which is used to measure the severity of tardive dyskinesia. Now, from a safety and tolerability standpoint, in these sort of short-term studies, really a pretty not very concerning side effect profile. So patients may have reported headaches, somnolence, diarrhea, nasopharyngitis, and fatigue as some of the more common adverse effects. And only 4% of patients treated with deutetrabenazine in this particular trial required a dosage reduction as a consequence of these adverse effects. Now, valbenezin, this is the fixed dose study designed for valbenezin. Patients were treated either with placebo, 40 milligrams of valbenezin, or 80 milligrams of valbenezin. And again, you can see that there's a separation in a dose response, with a greater response being seen in the patients who were treated with 80 milligrams per day. Another important point, both on this slide and the previous one, is that patients were already starting to see improvement, and there was a significant separation at 2 and even 3 and 4 weeks of treatment. And so when patients ask you the question, how long will it take for me to start seeing some improvement, you can really tell them within the first few weeks of therapy. So valbenazine side effects were reported as follows. Certain things like somnolence were a little bit more common in the valbenazine treated group than a placebo. There were also some slight increases in things like anticholinergic effects, balance disorders, headache, akathisia, but again, not like a high risk of prominent or problematic side effects. Now, when you look at the long-term data with these medications, this particular slide shows the long-term study, open-label extension study for deutetrabenazine. Patients were treated for, I think it was this particular report is for 2 years after the completion of the randomized control trial. Patients came off the medication and retitrated. So you see here again this initial and very rapid reduction in the tardive dyskinesia symptoms, and there's a maintenance of effect over this time period that the patients were followed. Now, it may look to you here in this slide that patients' reduction in AIMS kind of continued and maybe even increased over time. And that is still something that we're trying to sort out, but I just want to let you know that, or point out to you that the numbers of patients that were followed for this time period actually dropped. And so there might be some dynamics there related to the patient population that we need to keep in mind. However, having said that, on the clinician global impression of change and the patient global impression of change, patients were really, kind of a high proportion of patients were continuing to report continued efficacy of this medication over the long term. And so we can feel pretty good about the ongoing use of these medications as long as patients require them. Same thing with valbenazine. This is a 52-week open label extension study. Again, patients had to be retitrated, and there was the improvement in the early kind of weeks of treatment, followed by maintenance of control of their tardive dyskinesia symptoms, again on the CGI as well as the PGI, when patients were they were classified as either very much improved or much improved on either of these scales. Ongoing efficacy was perceived by both clinicians as well as patients over that year of therapy. Now, how do we choose between Vmat2 inhibitors for treatment of tardive dyskinesia? There's really not a good way to do that because there are no head-to-head studies of these two medications. And so you may choose different kind of features of the medications when you are approaching a particular patient to help guide you in your initial decision making. For example, if there's concerns about patient adherence, then the once daily dosing of valbenazine might be attractive to that patient. If, on the other hand, you feel that a patient might require some fine tuning for tolerability or other reasons, then you have greater dosing flexibility with deutetrabenazine, and you have the opportunity to really kind of find that effective dose. And I think, although there aren't any head-to-head studies, and we can't really say whether one drug is better in a given individual patient than the other. We know that patient responses are always going to be variable, and so if you have started and tried one medication and the patient maybe is not responding the way that you wanted or is experiencing side effects, it's certainly reasonable to try the other medication to see if they experience a better response or better tolerability. So again, just underscoring the idea that as you are doing this, to be in continued communication with the psychiatrist that is managing the patient. Again, these medications do require long-term monitoring from both a clinical, but mainly from a clinical standpoint, not from a laboratory standpoint. And so that means both neurologically as well as psychiatrically. And so having these ongoing conversations and communications about monitoring and dosage changes is absolutely essential. So another point that is worth making about the Vmat2 inhibitor therapy in tardive dyskinesia is that the trials were designed where the patients were allowed to remain on their baseline antipsychotic drug. So for whatever indication and for whatever dosing the patients were receiving, they just had to be stable on those for a period of time before entering into the clinical trial. And so all of this data that I showed you in terms of tolerability and efficacy and things like that were all in patients who were continued on their baseline antipsychotic drug. Excuse me. So if there is continued need to treat a patient with tardive dyskinesia with the offending agent or with the antipsychotic medication that they are taking, then we can actually safely add on a Vmat2 inhibitor and treat them for their tardive dyskinesia alongside treatment of their psychiatric condition. And so that should make the treatment landscape easier for some of these patients. There's also no evidence to suggest that Vmat2 inhibitors are different in their efficacy according to the underlying psychiatric diagnosis. So patients with schizophrenia versus mood disorders, or for whatever reasons they were taking those medications, there did not appear to be a difference in response. And there really was not any evidence that use of these medications was destabilizing the underlying psychiatric condition. Fairly confident about their use in these populations for those reasons. All right, so I think the last video that we have here is a patient who was examined both before treatment with a Vmat2 inhibitor and after. And you can see that there's definitely higher amplitude of movements here in the before, a lot more head bobbing, a lot more orobucolingual dyskinesia. You see some hand movements there as well. And in the after video, although they're not completely gone, they are improved. And this was a substantial improvement for the patient who was otherwise quite embarrassed by her symptoms. And so you can see that kind of magnitude of difference there. And that, I think, just underscores the importance of kind of working with the patient to, determine when treatment is satisfactory as opposed to completely eliminating all of the. All right, so in conclusion, tardive dyskinesia is often forgotten as a potential problem. And so as we talked about, first generation products were more commonly associated with tardive dyskinesia, but second generation antipsychotics are still also associated with tardive dyskinesia. And so it's still a very real and common challenge. And our understanding of the risks and characteristics of tardive dyskinesia have evolved. And so we need to kind of approach these patients in that context. Regardless, though, the consequences of tardive dyskinesia remain high, and once patients develop it, they really are going to be stuck with it, and we need to be mindful of that and also approach their management appropriately as a consequence. And fortunately, we have these newer treatments, specifically the Vmat2 inhibitors, that can make a large difference in patients' function and quality of life. And as we've talked about throughout all of this, having regular communication with the patient's treating psychiatrist is important. So with that, I will stop and I'll open this up to any questions that you guys might have. So I don't see any questions coming through. I'm not sure if there's a chat. I see a chat here, but I don't see any questions. But if there aren't any questions, then thank you for your attention and for joining for this tardive dyskinesia presentation. Enjoy the rest of your day.
Can you hear me?
Oh, yeah.
Thank you. Thank you very much. Could you comment if anything is known about the metabolism of psychoactive drugs by the bacteria in the gut?
Of the psychoactive, like the dopamine receptor blocking medications?
Yes, they have found that the intestinal bacteria can play a significant role in metabolism of these drugs, and that can differ from person to person.
Yeah.
Can be responsible for different effects of different drugs in different people.
Yeah, I think, so first let me just say that that's not my area of expertise, so I can't comment specifically on it, but I think you're hitting on a topic, like kind of a hot topic these days, right, which is how the gut microbiome really impacts a lot of different things that are going on, and we see that in other movement disorders as well, whether it has to do with the absorption, whether it has to do with the exposure, whether it has to do with other features or factors that can contribute to the overall kind of disease manifestation. So again, not really my area, but I think certainly part of what we're beginning to understand is just how those other factors, that there might be other factors that contribute to one of these.
Thank you. Thank you.
So yeah, I'll stick on for just a little bit longer in case there's anybody that does have any questions. But if there aren't any, then like I said, thank you for your attention and okay.
Thank you, Dr. Jimenez. I think we're good.
Okay, great.
Have a great day.
You too.
Bye.